My name is Dr. Natalie Crowe. I am a GP at Thornfield Medical Group and I am the Clinical Director of the East PCN in Newcastle. And I am delighted to say that from the 1st of December last year, I've now become the Chair of the Board of Directors of NGPS. In the room with me are Christian Townend, Chief Executive Officer of NGPS, and Rebecca Haynes, the Chief Operating Officer of NGPS. They'll both be talking you through some of the latest slides in the presentation. I'm delighted to be here with you tonight. We're looking back at the year of January 20 to January 21, and each of us here in this room of having to keep reminding ourselves what actually happened in that year. I think with the pandemic, it's thrown everybody off a little bit, and it's hard to remember what I did last week, let alone a year ago. But just to refocus our minds, that's the year we're talking about. And it's important to just remember which year we're talking about. Obviously, I'm a new face here to NGPS, and some of the changes that happened actually happened just in the recent months that have gone by. The previous directors of NGPS led on a proposal to make the PCN clinical directors become the new directors of NGPS. This was a decision that took some months to talk through amongst the directors, the clinical directors, the NGPS team. It was felt that this would be a really good way of trying to unite the voice of primary care in Newcastle. We're increasingly aware that in order to have a seat at the table for the big system-wide discussions, primary care really needed to come together with that unified voice. And until December, there were actually two boards kind of operating. The NGPS Director Board and the PCN Clinical Directors had their own board. So the previous directors of NGPS, as I say, really led on this proposal to unite the two boards. And that's what's led, after a membership vote last year that you'll all be aware of, the membership practices agreed that this was a good way forward for NGPS to continue. So from the 1st of December 2021, myself and the other 6 clinical directors of the PCNs became the NGPS directors. This is an opportune moment for me to pay tribute to the previous directors of NGPS, who were absolutely fantastic in supporting that forward vision of what we wanted primary care in Newcastle, the representative of primary care, to look like. And Anthony Moore, who, as you all know, was the medical director and previous chair of the board of directors. They have created and left for us a fantastic legacy of a company that has done really superb work, and that you know can be seen with the great efforts of the dealing with the COVID pandemic. So I think it's really important to just publicly say thank you to them for not only the work that they did, but also the gracious way they've handed over to us as a new incoming team to hopefully take up the reins and continue that success of the company. Moving on now to the agenda, I need to update you on some of the statutory responsibilities. Last year's meeting was recorded, and there is a link to the recording on the NGPS website, so if anybody wanted to go back and see what was said there. This meeting, as we've intimated, is being recorded as well, and that recording will be available on the website if anyone wants to review it, or anyone who wasn't able to attend today to listen to that. There isn't any plan for voting to be required tonight. If it were, I should remind everybody that to be quorate, there needs to be 50% of the member practices represented here tonight. Kate is hopefully tallying up who is here on this meeting in case that should be relevant, but I'm not aware of any plans for any resolutions to be voted on. If there were a vote, it's 1 vote per practice and equal vote per the membership practices. I can tell you that the accounts have been distributed. I think they came out with the meeting invitation. The annual report has been finalised and will be coming out to you in the very near future. And some of the slides we have tonight will talk you through some of the content of that report. As I mentioned, there are no planned resolutions to be voted on tonight, but I would ask at this point, does anyone want to put forward any resolutions that we weren't previously aware of? I can't see any hands, so if anybody does have a resolution, now is the time to shout out. I'll give you 5 or 10 seconds to do that if you wish to. No, can't see any hands being raised. Okay. The final thing to say is, if you're agreeable, can we wait till the end for questions? So if a question crops up while Rebecca and Christian are doing their part of the presentation, if you could note them and just wait till the end, and then we'll have a question and answer session then. Thank you. I'm now going to hand over to Rebecca, who's going to talk us through some of the finance slides.
Marvellous. Thank you very much, Nat. So I am going to start by just reminding myself and everybody else that we are discussing the fiscal year ending the 31st of January 2021. So just a bit of context in terms of the figures that we're going to present. And the other bit of context is that that would have meant that we were about a month and a half into the vaccine programme. So it was a very intense month and a half, but nevertheless, there were many months that followed in relation to that programme. So with that in mind, I'm going to present 2 slides. They're high level. We'll always take more in-depth questions either on this call via the questions at the end, or if you want to come direct at any time. But I've purposely kept this relatively high level. I'm going to talk about turnover, and then I'm going to talk about profit. This is our turnover since 2015, and you can see quite a gradual and then significant increase, including the year in question, which is 2021. So since last year, our turnover has gone from 3.8 million in 1920 to 4.7 million in 2021. That increase in turnover can be attributed to 2 main factors. The first is indeed the vaccine programme. So that month and a half where we were vaccinating, I seem to remember putting an Instagram post about how chuffed I was that we had done 10,000 people at this point. So we were vaccinating thousands of people, and that attributed to quite a significant jump in that turnover. The other increase in our turnover was linked to, again, the pandemic services, and that was the hot site services, and they kicked off around May of this year. So we had a longer duration of time to accumulate that income that's then reflected in this graph. The next slide I'm going to present is our annual profit. And when you see a slide that shows an increase in turnover, you would hope that the annual profit would reflect that, because that would reflect that we had retained the same margins as prior years. And you can see that that hasn't happened in 2021. So in 1920, we disclosed profit after tax, because remember, as a limited company, we pay 20% corporation tax, of £427,000 thereabouts. And that then reduced in 2021 to £276,000. And again, we can attribute that reduction to 2 main factors. As with any accounts, you can unpick this within a pound, but if we look at the 2 big chunky items that have led to that decrease, the first is LSIC, one of the practices that we look after, and a significant loss that was incurred in relation to that practice in that year. The second reason is that we actually recruited a number of staff in 1920, and we didn't recognise a full year of their cost because they were recruited within the year, so part of their cost of that year was recognised. But we had them for the full 12 months in 2021. So that full 12-month recognition then eroded that profit compared to the prior year a little bit as well. Lots more detail in our accounts. And as I said, if anyone wants to ask any further details, do just pop a question in the chat or ask us at the end or come directly to us. And on that note, I'm going to hand over to CJT.
Thank you very much, Rebecca, and thank you, Nat, as well. So again, I'm going to be talking about the year in review, which we all have to remind ourselves is 2020 to January 2021. And the first bullet on there really is recognition of the fact that the COVID pandemic really dominated all activity for that year, and really none of us need reminding of the impact that that had, not just on core services, but on the system-wide response to that. And where we played our part in that was initially with the delivery of hot services. So we recognised that the initial priorities during the pandemic were to establish those hot sites and the visiting service. And in conjunction with the commissioners who came out and asked us to respond to that, we looked at how we could see and treat patients with suspected COVID-19 in order to take that away from core general practice. And there were varying levels of success, I suppose, in how that was done. Our aim, as I said, was to take pressure off practices and other areas of the health service, and to try and ensure the safety of non-COVID patients requiring healthcare treatment at primary care levels. And this kind of knocked across the UTC programme as well as the core practice delivery. From the winter of 2020 and into 21, we were tasked with the strategic development, setup and delivery of the GP-led vaccination programme. And as Rebecca has already pointed out, that really went from flash to bang in a very short order. So the team was led and driven by Rebecca, but it was a team response across NGPS in collaboration with the clinical directors, and we came up with a programme in very short order throughout the early part of December, which was then went through governance checks through the commissioners, and we delivered our first vaccination programme at the Eagles site on the 23rd of December. And the rest in terms of that vaccination programme kind of is history, which dominated the year 2021. And we'll come on to talk about that in the next AGM. The primary care networks, we continued to heavily support primary care networks during this year with particular emphasis on the finance, on governance, on working up the schedules, and Rebecca and Annie were available, and Joe at the time were available to support the delivery of the primary care networks and support into that. And again, that was one of our key elements as described in that particular year. The next bullet point is...
Sorry.
It's all right. The next bullet point is the urgent access contract. And bear in mind, still, we're talking about 20 to 21, the year. We work, as you know, across a health alliance with Newcastle Hospitals and with Vocare as the out of hours contractor. There is actually a quadripartite agreement which includes NIAS, but NIAS on this particular contract are effectively a sleeping partner. But our urgent access contract, which is held by Newcastle Hospitals, and we have a memorandum of understanding, allows us to provide a system-wide response to urgent and extended access. And again, a lot of that was compromised when we had to make changes, particularly in the early part of 2020, where we used some of the services that we were being paid to deliver for urgent access. They were then moved into the hot services and the visiting service. And the final bullet I wanted to talk about was LSIC. LSIC made a loss during this reporting period. We have held the contract formally since October 2018. And in the previous years, we have not made a loss. But however, from October until the year in question, January 2021, we have shown a loss, and that's recently come to light. And there are three principal reasons, I think, for this loss. LSIC itself has had a number of providers over the last 10 years, and it's historically not been the easiest practice to run. I think there are some myths in there, but it's worthwhile pointing that out. There have been some significant management changes during that period, and indeed over the period in question, when we lost the practice manager, Sarah Lambert, who led the practice from being in a particularly dire place to being CQC compliant. So the management changes were one factor. The pandemic, which focused all of our attention in different directions. And the many providers, as I outlined earlier on, that have been part of the fabric of that. So they're the main areas really to concentrate on in terms of that year. Next slide, please. So looking ahead, we've had a number of strategic meetings now with our both our outgoing directors and our incoming directors to focus on where we need to be looking going ahead. And I want to draw your attention to the right-hand side of this slide to start with. And this is looking at strengthening our existing services. Urgent treatment centres are right up there. And I have to say, over the period from the 1st of February 2021 up until now, our partners in the Health Alliance have been very supportive in terms of the asks that we've made from a general practice perspective, bearing in mind that there has been a very dynamic, flexible service that has been required to be provided, given the fact that we've had a COVID response there. And it has meant that the service has at times been suboptimal, but we are working and this gives us a fresh opportunity to look at what we can do as well as possible, working to try and provide a true deputising service, which was the original intention of the urgent treatment centres. The COVID response will continue, and from March this year, our expectation is to create a fixed evergreen service, which Emily is fully costing out with Annie at the moment, with a small pool of permanent staff. And the emphasis on that will be on outreach, particularly, I think it's fair to say that the large sites, unless there is a fourth vaccination requirement, the large sites I think have run their course. So we'll be looking at that dispersed model, getting out into the community and getting to those hard to reach individuals and communities. Running practices in need. As you'll be aware, we are moving away from this, and we've already given notice, particularly for Avenue, that we are moving away from that particular contract, and we're in discussion at the moment with the CCG in how we can best support the practices in that area, but also divest ourselves of the responsibility of Avenue, which was novated to us on March the 31st, 2020, so within that reporting year. Asylum seekers support, there's been a lot of work that was actually done in September to December of 2020, where we worked into 2 hotels. But going forward, we've signed up with the commissioners to deliver asylum seekers support, and we hope to link that into LSIC practice as one of the focuses in the hubs. What that has meant is that from going from 2 hotels, we've now got 5 hotels, so 5 GPs supporting that work. But when I hear some of the grisly stories that come out particularly from the social link workers that are working in there, it really, this is a service which is much needed as we go forward. Talks about the social prescribing services at the bottom of there, and we are looking at reviewing how we manage that, because in the past we have employed social prescribing link workers as part of the ARS, but that may change, and we're reviewing how we do that. So strengthening our existing services going forward. We've also got some new and innovative projects, and I'm very conscious of time. We've got some people such as Chris Galley, who's on the call, who's looking at the flexi pool for the GP workforce, because as we all know, workforce issues continue to be the most dominant feature in terms of how we provide that support to core general practice. But included in there is something around research, which we recognise has been something that we've wanted to engage on, but for very real and realistic reasons, particularly COVID, we've not been able to spend the time. The other areas in terms of GP outreach, community diagnostic hubs, are all of the new and exciting projects that we are looking forward to trying to reach on to. Okay, I'm going to move away from that, and do you want to talk to this?
So this slide just shows our sort of refreshed core statements with mission, vision and values. This is something that the new incoming directors we've been working on just with that change in leadership of NGPS. And I'm not going to read out the whole slide to you, and I appreciate it's quite small to see. But with our mission being that we want to lead on strengthening general practice in Newcastle and ensuring the best possible experience for our colleagues and the communities we serve, we're really conscious that it's been a really difficult time for primary care, as it has for the whole of the health service, pre-pandemic, but especially during the pandemic. So we felt it was really important to have that stated in our mission, that we really value the input of colleagues and ensuring that colleagues are supported, and obviously patients and the communities that we serve. I think we're reaching the end of our presentation slides, but in summary, I would just say that NGPS has been such a successful company, and this year that we're talking about again was an incredibly successful year. The way the company was able to turn around its pandemic response to this sort of global emergency was absolutely breathtaking, and I can't really heap enough praise on the team for the hours that they put in, putting their own lives on hold really to do that. As Christian intimated, because the focus was entirely on the pandemic, it did mean that we perhaps took our eye off the ball on some other aspects of the work, and particularly, when we're talking about LSIC and the loss that we know has happened in this financial year. But that is something that now we're aware of. We've put on in really robust plans to turn that around. So Tracy Carr has come in as the new manager at LSIC and is doing a fantastic job. Her and Christian and Annie and other members of the team have looked very closely at the staffing levels and really turned around the situation there. It's also led us to review other aspects of the NGPS work. So bringing in some specific accounting software that would make it easier to keep track of financial issues, financial reporting, and some of the governance procedures, which, we hold our hands up. During the pandemic, everyone's attention was focused on the emergency that was the pandemic. But now we've had time to slightly step back and look at what's been going on. There are changes that we've made, and I think that gives us a really positive look to the future, really, for NGPS to be able to do some really interesting, exciting and innovative new work, but whilst preserving the values of core general practice as well. I think now we've reached the end of our slides, so I would invite if anyone has any questions or comments, and I guess if we can bring up the chat, Rebecca, we might see if
what I'm going to do is I'm actually going to stop sharing the slide deck just so that we're able to see you all and then chair any questions that are coming our way. So just bear with me a second while we do that.
And of course, I haven't got my glasses on, so I can't read. I won't be able to read the chat.
So I can help you out with that, Nat. Yeah, no bother. Right. So in terms of questions, can I invite folks with any questions to raise a hand, and we will field those between the three of us.
It's going to be a stunned silence.
The tumbleweed coming.
Is there anything in the chat?
There is nothing in the chat.
That isn't the chat though, is it? That's...
No, I could just, it comes up with a little, little bubble. Sorry. Yeah.
Okay.
Okay.
Oh, one hand.
We've got a hand. We've got two hands.
Mike, good to see you. What's your question?
It may not be the right time to ask this question, but you've mentioned moving away from running practices, and holding those contracts, I believe, is key to being able to fund hold for the PCNs. So I wanted to know, obviously at the minute it's just the Avenue surgery that you've given notice on, but what are your intentions for the other contracts, and if you intend to divest all of them, what happens then to your role with the PCNs?
I'll do that one.
Yes.
I'll do that one, Mike, just as the kind of the PCN finance person. You are correct that we need an A code in order to receive the income through NHS England Exeter process, and our intention is that that will be retained in LSIC. So our current strategy is to retain LSIC while we continue a recovery programme, which we deem to be quite long term, and not to lose sight of the fact that actually LSIC didn't just enable us to look after the PCN finances, but the entire vaccine programme would have been impossible without LSIC, because again we needed an A code, and principally we needed a primary medical services contract, importantly for that DES. So you're bob on, it's very important, and strategically we'll always consider that in any of the decisions we make, and at the moment the decision is to retain LSIC and to make it strong and to enable us to do all the stuff we need to do via LSIC.
Just to add there with regards to LSIC as well, you know, LSIC did allow us the opportunity to use the site to deliver the hot service from, and if we didn't have LSIC, we wouldn't have had that ability to respond in such a very flexible and dynamic way. So again, notwithstanding the A codes on that, but the ability to actually use that was very helpful as well.
Lovely, thank you.
Thanks for the question. Anybody else? Patrick?
Just asking, good evening everyone, but is it appropriate to, for me to ask how much loss was made by LSIC, or would that be in the, I'm sorry I haven't read that report this afternoon, would that be in the report that was sent in the accounts?
We've not got that level of detail.
Okay.
So if on the accounts on page 13, into that accounting period, it shows that there was a £70,000 loss that was incurred by the practice over that reporting period. And that's largely because the sustainability funding that was made available to the practice ran out in October 2020. And that sustainability funding was there to move the practice from the very poor place it was at. It wasn't CQC compliant, it didn't have GPs working there, to be in CQC green and having appropriate staffing levels. However, go on, you.
Yeah, I think you were going to say, or what I was going to come in to say is that one of the real improvements that is very important in my mind is the scrutiny in the financial reporting process that we have. And we're going to implement SAGE, which will enable us to really dig further down into our accounts. And also we're exploring a external audit of the retrospective accounts, just to get complete assurance around those financial figures, Patrick. So just a bit of assurance in twofold. First, a new financial reporting system, and second, some sort of external scrutiny, just to give us and our directors assurances regarding the figures.
Is it worth saying that broadly that loss has been due mainly to locum costs?
Yes. Yeah.
So it's very clear from the financial reporting that's been done in-house that it was costs to locum services that unfortunately have accrued that loss, which has kind of ran away with itself before people became aware quickly enough. But yes, as Rebecca says, the new things put in place should make that very
much easier.
Yeah.
Just to contextualise that so everybody's aware, we became aware of this in October last year. So this was within this current accounting period, and so have made, as we've said, in conjunction with the practice, and I meet with Tracy Carr, who's a really solid and dependable manager at the practice, well supported by other practice managers in the area, and we are looking at the recovery programme, which is why we want to invest long term in a strategy, not only for the A code, but to ensure that we do the right thing by LSIC and retain it to sustainability. It's the right thing to do.
Just got a follow-up question, CJT, from Marie. Is there a loss expected for LSIC for 21-22, and if so, how much?
Yes, there is a loss expected for this reporting period. Again, when we came to light, that loss looked at an eye-watering figure of around £480,000. We have done significant amount of work between October, when that came to light, and now, and that looks at the moment at around 270,000. But we're still working on how we can ameliorate that as much as possible. It is grim. It is not great in any respect, and it needs to be exposed. As the chief exec, I take full responsibility for that, for what occurred under my watch. It was a complex period of time with a lot of moving parts, and that's not to excuse what happened there. But that does look like the loss that will be incurred within this reporting period.
I would just step in there and say, although Christian as chief exec is quite rightly saying that he takes full responsibility for that, I think it would be unfair for responsibility to solely sit on his shoulders. There were a number of different people who had a degree of responsibility to the oversight of the running of LSIC during this period that we're talking about, and not all of them even associated with NGPS anymore. So I think it is important to say that, yes, you're quite right, Christian, and thank you for making that statement, but there were many other people involved, and as we've stated before, the emergency of the pandemic meant that people who normally would be keeping a very close eye on what was going on from NGPS's perspective were working 12, 15 hours a day on the pandemic response and were not able to do their usual daily work of keeping an eye on things. And that, in conjunction with the unfortunate multiple changes in staffing from the LSIC management side of things, just meant that this got lost in the melee. And yeah, we're not here to sit and make excuses for why this has happened, but hopefully reassure you that now we are aware that there is a major problem. We have taken great steps to mitigate the problem and to plan for the future, not only to turn LSIC round, but also so that something like this couldn't ever happen again.
Any more questions, folks?
Maybe just one more last one, just for my own understanding. It's not, like you rightly said, might not be anyone's fault this happens, but does the CCG, maybe that question, do they help with such financial losses, especially as you mentioned, there are lots of mitigating circumstances, like the fact that you were helping out with the COVID sites and all the other aspects of work that the NGPS was doing. So does the CCG help in any way financially to help with those losses or not?
I'll pick that one up, Patrick. So yes, we have made the CCG aware of this when we found out about it, and we've approached the CCG, but not with a begging bowl. We think we can cover these losses with our surplus as it stands at the moment. It's important to bear in mind that the CCG as commissioners were supportive of financial remuneration, but that would come at the expense of that money being used to support core general practice. And we felt that it was not appropriate to divert money that needed to go to core general practice towards supporting LSIC. So we took a decision that we would not ask for that support, that financial support, and we would manage this ourselves with that long-term strategy, so that effectively the practices were not dealt another blow with regards to that.
But yeah, it's a really good question to ask, Patrick, and we did have a meeting, and a very open and very supportive meeting from the CCG, who, because we wanted to explore every option that was available to us. And I think in answer to your question, apart from what Christian just said, is that actually they very likely would consider additional financial support for LSIC, but really we don't think that that's the right way forward. As we've intimated before, you know, LSIC has been historically a difficult practice to run. In the 10 years it's had, is it 3 different people, owners, or 3 different organisations trying to run it, and it came with some financial support from the CCG to try and turn it round, because I think when NGPS took it on, it basically had no staff. It was failing at CQC, so the CCG did put in some funding for 2 years. Really, I think the way this is, one way of looking at this is obviously that money did support LSIC for the 2 years, and NGPS has now ended up supporting it for this previous year. But what we can't do is continue to do that year on year. And I think there may well be questions in the future and decisions to be made about the viability of that practice, given that successive organisations have struggled to make it financially viable. I think we're feeling rather more confident at NGPS that we do have a viable plan in place for the future over the next couple of years. But, you know, at some point, I think as you know, the wider system, the CCG, and as practices, membership practices and NGPS, we do have to ask the question of, you know, how much resource and finance can you plough into one practice out of 31 in the city that is continually struggling to cope? So, you know, I put that out there as a question for us all to ponder. Something for the future. Absolutely, but just to reinforce the message, you know, we've got and I don't know if Tracy's on the call, but we've got a really robust manager in place, working really confidently with the staff and to turn this around. And we are determined, all of us, Tracy included, that will happen. Just to contextualise this, Patrick, and I know you'll be aware because of that part of the city. If you recall, Ponteland Road was divested of its patients, and that had a huge impact in the west of the city. And the directors at that time then took the decision that that couldn't occur with LSIC because there was nobody else prepared to pick it up. And so, you know, that led to that decision 3 years ago now to take the practice on and try to turn it around. And I think it's fair to say, particularly with Tracy's dynamism, that practice has been turned around. We just now need to sort out how we manage the financial aspects of it, given that running a salaried GP service is very different to having a partnership service. And one of the ways that we're doing that is by developing the asylum seekers modelling, the financial modelling into LSIC, and Tracy's done a lot of work around that alongside the team here, so that does take some of the pressure off other practices, because we know that asylum seekers come with a lot of problems, and we want to try to work that into LSIC. So that will be the modelling for the future as well.
Got another question from Mike.
If I can find the unmute button, sorry. Yeah, so I appreciate that you're obviously working very hard to reduce that deficit that we're expecting in the reporting period to come. I guess my question is, we've benefited from dividends when NGPS has been in profit, and it sounds like you're on course to cover that loss with your surplus from elsewhere. What happens if you don't cover it? What happens if there's a loss overall for NGPS?
So we're confident that we can cover that loss. As you have seen, an email went out today with regards to the pound per practice and pound per network that the directors have directed that we send out to practices. That is not a dividend. That's a response to the surplus that was created in one part of the business around the vaccination programme. But I can give you an assurance that we can cover that loss at the moment, and not place ourselves into a difficult position.
I just wanted to make it really clear the separation between the vaccination money, because that's actually PCN, it's through the PCN DES as opposed to NGPS Limited. So we've we have kept that vaccination money completely separate from NGPS operations, which is why it's not described as a dividend.
I was just going to come in on that point about, you know, if we weren't able to cover the loss of Telsic, that would have changed our conversation that we had with the CCG. I think it's because we're confident that we can cover the losses with some of the things that we've put in place that we think that, that's why we've come to that decision, that we are not going with a begging bowl and asking to be sort of bailed out, I suppose, is
like CBC too. Yeah.
Which absolutely, as Rebecca says, which is exactly what happened with CBC and Gateshead. They had to hand back their practices and essentially be bailed out by the CCG. And that's why I said when we met with the CCG, they were very open and supportive to look at whether that was necessary. But in some ways we feel quite, well, obviously we feel responsible for what's gone on in Elsick, and therefore want to deal with it ourselves as a company and not have to rely on a handout from the CCG. Again, it goes back to what I mentioned about this is a practice that has had, unfortunately, money thrown at it. And, you know, at some point we have to start thinking about drawing a line and saying, well, let's not keep throwing the money at it.
And this year, just to be clear around dividends, Mike, we don't have a dividend policy whereby we wipe our reserves every year. So the funds that are being used by NGPS to bail out the practice are cumulative reserves built up over a number of years, which have no link whatsoever to the vaccination programme.
Yeah.
Any other questions, folks? Got one there, Marie.
Sorry, hi. I'm just wondering, as and when, or is it viable to continue with the practice, and have you any thoughts on how long you're going to sit with it for before making a decision as to whether it's viable or not? Because 270,000 loss is a significant amount of money.
We're committed to a 10-year contract with the practice. We took it on in 2018. We have got the interests of the patient population. It's a practice of about 7,000 patients or thereabouts, maybe slightly less. I completely get the question around how viable that is, but I am confident that we can make changes. You know, when I opened by saying that the original eye-watering figure was double where we find ourselves now, and in that short space of time, we've been able to find the monies that should have been there because we didn't have the management structures in place at the time to ensure that that was there. So I don't think it's fair to make a pronouncement right here, right now about Elsick going forward. Suffice to say that it is part of our portfolio in terms of its A coding. We are committed to supporting the staff there and the patients in that area and the west of the practice, west of Newcastle, and we will continue to focus very closely on getting the practice back into a sustainable footing.
And I think realistically, if NGPS wanted to be released from that 10-year contract that you've just mentioned any earlier than 10 years, the practice would really have to be in a viable position for anybody to want to take it on. So there's certainly, I don't think we have any plans to, get rid of, for want of a better word, of Elsick in the next year or two. I think it's going to take some time now that we've refocused our attentions on it to turn it round. And if we get to a point where it seems that would be the best plan, that will obviously have to involve discussions with the commissioners, NHS England, the local population, the neighbouring practices who would be obviously affected if the practice was either to close and be dispersed or whether it was to be taken over by somebody else. So there would be, an enormous amount of discussion to happen before we ever got to that point.
Anybody else? Any more questions? Claire?
Yeah, I have to say I do agree with Marie. Is there any support we can offer to ELSIC? Because in the bigger picture, we're all in this together. So it may be that we can offer support to Tracy, like going forward and making this work, because it's going to come back on us all at the end of the day.
That's a really lovely offer, and thank you so much for that. Christian, you're closer to the day-to-day running with Tracy, but I'm sure you can link in with.
That is really, I mean, that is a really generous offer, Claire, and I'm delighted that you made it. Thank you for that. I think, to be fair, Tracy is on top of this as the manager there, and has been supported by a number of the previous practice manager directors. But, you know, not wishing to put words into Tracy's mouth, we are all in this together, and we are all looking at a solution. So it may be that we do come back to you, Claire, and others on the call if there is a way forward. So thank you for that offer.
Anybody else? Please don't be shy if you're thinking, if you're hovering over, putting your hand up.
No, doesn't look like it.
No.
Okay. Well, thank you everybody for joining. It looks as if that's the end of the questions, so it just remains for me to say thank you all for joining, and I declare the meeting closed.
Thank you.
Thank you, everybody. Have a good evening.
Bye.